Good morning, everyone. Thank you for joining us. I'm going to spend a little bit of time switching gears and talking about shoulders today, and specifically in the realm of shoulder replacement. I know we're going to have a little session on replacements in knees, hips. I'm going to address the shoulder here today. I'm not advancing. Am I not advancing? There we go. All right, so first we're going to go through some indications for total shoulder arthroplasty, the types of arthroplasty we do, which are referred to as anatomic and reverse. Also talk a little bit about revision and what situations we may need to revise a replaced shoulder. I'm going to really kind of focus a little bit on the preoperative planning part of this, because this is something that we're seeing a lot of changes of in recent years, and how this is improving our outcomes within shoulder replacement. And also some special considerations that we have to address to try to optimize our outcomes. I will touch briefly on some of the future directions and some of the new things that are coming up through the field, and I've put some websites on there if there's more YouTube videos or things like that you'd like to see. So we're going to talk about glenohumeral arthritis and rotator cuff arthropathy. So when we talk about arthritis, it's not all created equal within the shoulder. Sometimes people develop true, bone-on-bone, ball-to-socket arthritis, and then some people do get arthritis that's secondary to a deficient rotator cuff. So while these are both termed quote-unquote shoulder arthritis, we do treat them a little bit differently. You may see some patients that come in with shoulder pain, and when you're starting to think about arthritis, you're usually going to see decreased range of motion, trouble reaching up, over their head or behind their back. Can't put on a belt. That's a common thing you'll hear. A lot of pain at night. That's one of the cardinal signs that we see is people say, I just can't sleep at night. My shoulder hurts too much. Difficulty lifting. Maybe they had an injury in the past, or if they had prior surgery, specifically a rotator cuff repair. So when we talk about replacing a shoulder under these conditions, we have two options. Simply put, there are more, but for what we're going to talk about today, we can replace the ball and socket with a new ball and socket, or we can do something called a reverse, which is where we switch the components, and that's in a situation where there's a rotator cuff deficiency. So these are kind of schematics, and this is what it looks like more radiographically. On the left side, we see what we refer to as an anatomic total shoulder, where a ball and socket is replaced by a new ball and socket. On the x-rays, you can't see it on the x-ray, but on the socket side, there's a polyethylene glenoid, or a new piece of plastic that goes in there. You can see there's like a little dash sign. That's how we kind of track where that piece of plastic is. But basically, it gives us a surface that allows the patient to move their shoulder. The rotator cuff is intact and will help kind of function the shoulder. But in the situation where the rotator cuff is deficient or irreparable, sometimes in situations where people have had a fracture, or in people who have had a prior anatomic and that has failed, then we can switch them to this procedure called a reverse. And that's what it looks like on the right side. We essentially put a ball on the socket, and the socket side, or the ball side, becomes a socket. So these are our two options for treatment. In some situations, we'll talk about revision, and that can be when an anatomic total shoulder has a rotator cuff that fails over time, if the components loosen or dislocate, as you see in this x-ray, or if there's a fracture. Unfortunately, if someone had a shoulder replacement and then falls and fractures, then oftentimes we'll revise to a reverse. But one of the things that we found over the years is the position of our implants is really critical. It's important to see our good outcomes, to limit the complications we have, and obviously some of the complications that lead to a revision can be, the glenoid or the components loosening or instability. So putting our pieces in the right spot is really, really critical. So in terms of preoperative planning, we always have x-rays, and in most situations we'll get a CT scan as well, and that gives us more of a three-dimensional sense of the shoulder. In some situations, patients will also get an MRI if we're wondering, the integrity of their rotator cuff. And what we're looking at is kind of the shape of the bones and what we refer to as version, and we'll talk about that a little bit, but that's really important to our preoperative planning. And then what we can do is now we're taking this into computers to do more 3D modeling, and this allows us to improve where we put our components and also get a better sense of the size of our components and where exactly we're going to put them. We're finding that this is pretty accurate. So when we're taking a pre-op plan and then taking it into the OR, we're not making a whole lot of changes with the software and the computer systems that we have these days. So this is one example. This is one company. I'm not going to get really much into the proprietary nature of this, but there's a lot of different companies that have these types of programs. And you can see This particular plan allows us to really center on the socket, which you can see kind of two views from it on the top, and that allows us to place our implants, which you see down on the second part or the lower level, really very precisely within the socket. This is another system. This is one I use frequently, and again, it gives us nice 3D pictures. It really gives us a sense of the shape of the bone. Are there bone cysts? Are there bone spurs? You know, where are things relatively speaking to where our implants are going to place? So on the left side of the screen, you can see this is that kind of plastic piece that goes on the socket. On the right, you can really get a sense from the side, from the axial view, where we want to put these. It tells us how much coverage we have, how much angulation we're going to do, so it really helps kind of give us a good sense of what we're getting into. And we can do this on both the ball and the socket side. This is, I'm going to bring it into here. So this is a reverse shoulder, and again, we're seeing the position of the components, the shape. So in this upper right picture, you can see the shape of that socket and how much it slopes backward. We'll talk about that a little bit more, but that's what we refer to as version, and that can sometimes get us in a little bit of trouble if we're not very respectful of that going into surgery. Again, giving more sense of what the component sides are. And then one feature of this too is then we can see a 3D model and we can get a really good sense of how this shoulder is going to move in space. Are we going to be bumping into things? What kind of expectations can we have for post-op range of motion? Okay. So other considerations. So version is essentially talking about how much the socket angles backward, and that's really important. If you're getting above 15 degrees, you can really run into trouble and therefore get some instability afterward. Depending on the shape of the version, sometimes you can just correct it by how you ream when you're getting ready to put your components in. Sometimes you have to use different shape or size components, and sometimes you do have to bone graft depending on the situation. Another thing that we have to think about is bone loss. So for some of these patients, they've lost bone just because of the type of wear or because they've had a prior surgery. And in some situations where there's extreme bone loss, we actually have to get implants that are designed toward the patient's anatomy to make it fit better. So we always look at the shape of the ball and the socket relative to each other. So these gives you some examples. A type 1A or A1 is going to be pretty straightforward, but if we get into a B2 where there's almost kind of a wave to it, that's going to be a little bit harder to put components in. And these are some examples of some of the shapes, so you can have augmented or thicker ones, you can have wedge shape. It's harder to see on here, but this has pegs versus what we refer to as a keel, and all of these are going to help kind of give each patient what their anatomy needs to have a better outcome. This is an example of that vault reconstruction. It's a big piece of metal. It's kind of amazing when you see it, but as you look on the picture here, you can really see how this has reconstructed a lot of the socket to have a better outcome for this patient. So these are some more examples when someone's had significant amount of bone loss. You can put this large component in there, and that's really going to give them the most stable shoulder moving forward. Some other things that we're looking at in the future, there's some augmented reality that comes in, and this is one of those websites that if you're interested in this and you want to take a look at it, this is where some surgeons that you see in the upper corner, they actually wear virtual reality goggles, and when they're operating, they can have things in space and kind of move it around, and it can help kind of dictate where your implants are going to go, the shape, the position of things to hopefully have more accuracy moving forward. This is still very early. We also have a couple companies that use navigated surgery. You're going to hear more about this with the hip and the knee, but this is also something that you can put some sensors on the patient during surgery to help with some accuracy. Again, not as common in the shoulder right now. And then also robotic surgery, again, not as common in the shoulder, but something that is being looked at more commonly, and more research is being done to see if we can increase our precision and our bone preparation and implant sizing for future use. Thank you.